and welcome everybody to this evening meeting. I hope that we can actually have a discussion that is helpful for you and your families. I don't have any disclosure other than saying that I think I have been, as many of you and many of our colleague clinicians in both sides of the counter, as a professional clinician treating individuals with dementia and cognitive deficits and their families, and also in the other side as a caregiver myself. So I'd like to actually share my screen now so I can get some slides here. Okay. Are you able to see my slideshow?
Mm-hmm.
Okay. All right, so I think I'd like to start by saying something that you all know firsthand, because if you're here, that is because you have experienced this. But for many years, when people talk about dementia or cognitive deficits, it was actually kind of limited to that, cognitive deficits, memory, concentration, attention, language, which are definitely symptoms that can actually interfere with somebody's quality of life. Now, since the very beginning of history of medicine, people also have identified neuropsychiatric symptoms when it comes to cognitive deficits. In fact, I should say that back in 1906, 1907, the German neuropsychiatrist Alois Alzheimer's described his index case, his first case of what he called Alzheimer's disease, or somebody else later coined the term Alzheimer's disease or dementia, in an individual who presented with symptoms of jealousy about her husband, agitation, difficulties with sleep, and later on actually came to have problems with memory and what we call executive functioning. So I think it is very important to recognize that neuropsychiatric symptoms of dementia are very prevalent. They're very common in individuals that present with cognitive deficits. And I suspect, and I'm assuming that many of you have also noticed how disruptive these symptoms can be in somebody's lives. Neuropsychiatric symptoms have different flavors, different clusters. And sometimes they can present with depression and anxiety. Sometimes they can present with paranoia, sometimes with motor behaviors and agitation, sometimes with what we call delusions and hallucinations, disinhibition, personality changes. And once again, in many cases, they can actually be more disruptive to the quality of life and the wellness, not just of the individual, but also the family around. I love that Judy actually put this slide and she was explaining to me about this very nice phrase. And you kind of stimulated Judy for me to actually go and check Rosalind Carter's website and how she has actually been an advocate and a promoter for caregiver research and caregiver support. And I think the phrase is very wise, as you can see, right? There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. So I think that actually speaks for the cycle of life. If we're lucky enough to live long, and if we actually experience some of the normal aspects of aging, let alone having a cognitive deficit, we'll recognize that we'll go through phases where we can actually be caring for somebody, but we may actually be in the other side of the spectrum at some point. And I think that's lovely to actually keep in mind. I will say, before I actually move to the next slide, when we talk about caregivers, by definition in clinical terms, we usually talk about the closest relatives or friends of an individual. And we usually take into consideration the fact that this person is not a professional, and it doesn't. This person doesn't get any financial compensation for the care. In fact, as many of you know, it may actually out of love and out of care that you're actually shift your role within a couple or within a family. um, caregiving has consequences. And I think many of you, if you're here, I think you may have actually been, protagonists of how physical distress, decreased quality of life, emotional burnout, financial constraints can actually present as part of your experience. 74% of caregivers in 2015, as you can see in this slide, were concerned about their own physical health. And I have to say that in my practice, and many of us clinicians, colleagues here, we have seen that people actually neglect themselves very easily when they're trying to take care of somebody. And there's also some feelings of guilt about thinking about oneself, which is something that seems to be very natural, very human, but also something that can be detrimental. So again, emotional distress that can also lead to clinical syndromes of depression, and that are more prevalent in the population of caregivers as compared to the general population. And that, of course, leads the way to more consequences when it comes not just to the family, the individual, the caregiver, but also for the society. And I think nowadays we recognize that the consequences of dementia for the individual, the consequences of caregiver burden and burnout are public health issues. So when we talk about caregiver support, I think it is important to understand the culture and the family dynamics. I think it's very important for us as clinicians to understand that not one size fits it all, that we, as much as we try to provide evidence-based assessments and treatments and care, we have to tailor our approaches, not just to the personal circumstances of individuals, but also to the personality and the character of the family that is taking care of that individual. Just as an anecdote, I will say that you may have seen that members in the family have different personalities themselves. My experience within my own family and also caring for patients and families with cognitive deficits is that most of the time, members of the family are willing to help and they're willing to actually pitch in and actually share the burden. But the different characters are actually interesting to understand. So usually we have the the one that is the go-getter, actually, that will be the one that recognizes problems early on and comes up with solutions early on as well. And I suspect that the ones that are attending to this talk today might be in that category. There might be some other members of the family that require a little bit more prompting and cueing to actually pitch in, but it's important that it takes a village, as they say, to actually get somebody to have the care and the love and the type of treatment that is needed. It is important to actually understand that there are resources, to being educated, as many of you are. What are the preferences? Once again, we have to tailor our approaches to our patients and our families and not the other way around, not to actually fit our patients into our formulas or tools. And I think it is important also to come up with plans of how to actually address changes, how to address progression of the illness, and also how to address being compassionate with oneself. Caregiving can be very, very rewarding, as you know, but it can be also very taxing in every way. And I think it is important to recognize that it can be exhausting. And sometimes people may actually feel as they want to quit. And I can speak for personal experience. You know, when I was in medical school, actually taking care of my grandmother along with my mother, it was quite a time. And I think it was very important to recognize that even when you do something with love and care, sometimes that can actually be exhausting and you may actually need a break. So it is important for you to keep in mind that self-compassion, self-care has to be in the formula. And then, of course, in society, we hope, and in the health system, we hope that we can actually start to address some of these issues by working with different disciplines and multidisciplinary teams. Some terms that are important for us to understand when we make assessments and also when we craft treatment plans is to understand the difference between syndrome and disease. Syndrome will be a collection of symptoms that can be provoked by different etiologies, by different causes. So for example, you may have experienced yourselves that sometimes a loved one with dementia may actually become confused, right? And that might actually be related to many different situations. One of them could be progression of the illness. Another one could be maybe a metabolic problem, maybe a recently prescribed medication. So that will be a syndrome, something that may have different etiologies. A disease has more identifiable etiology. And for example, in the case of Alzheimer's disease, we talk about the accumulation of some proteins, waste products, tau protein and beta amyloid in the cells and outside of the cells, respectively. It is important to recognize that the basis of these symptoms is in the brain. I think there's been this debate for centuries, actually, about the difference between matter and mind and body. And the reality is that in all of these items are really intertwined and integrated. And that what we see as a manifestation of a symptom, a psychiatric or emotional behavioral symptom, has to do with interruptions of circuits, pathways, areas of the brain that are not functioning optimally, or that are not actually self-monitoring some other areas of the brain that are acting out. The way I like to describe it is like if you had like a program of missiles and you have a radar and you want to actually have that radar actually capture any potential missile shot, right? Areas of the brain like the frontal lobes, for example, are constantly monitoring and inhibiting many of the triggers that come from more deeper areas of the brain, like the limbic system that has to do with very basic functions of our survival. I think it is important also to understand the role of medications. I think so far we have some evidence that medications can be indicated, but I think in the other hand, we know that non-medication treatments tend to be more effective. Although I want to make with the caveat, I will say that non-medication approaches are difficult to carry out. And it's difficult also for individuals at home to carry out 24/7. And that can be very taxing, and that might be a sign that professional help is needed, and also the use of medications might be indicated. So when we talk about cognitive deficits, we talk about a continuum, a progression. And we have, for example, the terms of MCI, mild cognitive impairment, mild, moderate, and severe dementia. And I think in these cases, we try to correlate different cognitive functions with different affective functions and how they translate into the day-to-day functioning of an individual and how much assistance that individual needs. So, for example, clinicians, we talk all the time about activities of daily living, for instance. The way I explain activities of daily living is the type of activities that you carry out from the time that you wake up in the morning, you get up from bed, and you get ready to go out. So what do? You may actually go to the toilet, you may actually pee, you may actually have a bowel movement, you may actually take a shower, you may brush your teeth, comb your hair, dress on, and then you're ready to go out. So that will be basic activities of daily living. Then we have instrumental activities of daily living, which will be the ones that you carry out to actually being able to live mostly independently in the community. Those are activities that usually have multi-steps that require more concentration, require more executive functioning, more monitoring, more mental flexibility, like, for example, driving, buying your groceries, paying your bills, setting up appointments, and so on and so forth. And in this continuum, in this spectrum of MCI, mild, moderate, and severe dementia, we see decline initially with instrumental activities, and then you see decline in basic activities, and then you have maybe experienced the fact that an external help is needed to actually carry on activities of daily survival. So that's actually part of how we predict and monitor progression. We actually try to focus on not just the cognitive functions, like let's say attention, concentration, memory, language. When I say executive functioning, is the ability to generate thoughts, ideas, feelings, behaviors, actions, and being able to create a plan to carry out specific and to aim for a specific goal, and being able to self-monitor and adjust and improvise if there are things that may actually become obstacles in the plan. That would be executive functioning. Behavioral and environmental recommendations, I think, is clear when we evaluate individuals with dementia that changes are difficult to carry out because the brain is not able to, kind of reset in terms of orientation many times, or reset in terms of the ability to process information at a given time. So that's why it's important to actually provide external cues and prompting that can actually make the processing of information, the integration of information a little bit easier. And then there are cases of safety that become an issue for not just the safety of individuals, but also for the safety of the caregiver. Many times I have seen that spouses or adult children of individuals with dementia suffer from injuries in trying to help and contain their loved ones. And that's very important consideration for us as clinicians to keep in mind when we're trying to make assessments about the needs and the potential ways of outreaching for help. And then advanced care planning is a discussion that is based on the prognosis, is based on the progression, and I think it's something that we need to provide an open forum at the pace of each individual and each family. But it's something very important because I think, as we expect progression of the condition, it's good to know that there might be some other external supports that can actually be provided. And this is where multidiscipline teams are actually very important. MDs, social workers, psychologists, nurses, and community health workers can be very crucial actually to help with these aspects. In this slide, I'm showing what might be like the algorithm of how we make an assessment about a behavioral problem in the context of dementia. And I think this actually assumes that we're actually comprehensive about our assessments, that we don't think just about the symptoms, but we try to understand etiologies, and we try to understand different biological, psychological, and social factors that might actually be playing a role. So as you can see, we're trying to identify symptoms, but in each case, we try to understand if there might be some other medical comorbidities that might be affecting not just cognition, but also behavior, sleep cycles, and other metabolic balances in the body. And that sometimes can actually be just enough actually to help with some symptoms of agitation or paranoia or insomnia or wandering, just actually make sure that we correct some of these medical problems. There's been this term that we use in neuropsychiatry that is called unmet needs, trying to understand if there are some issues of medication side effects, as you can see here in this slide: pain, discomfort, being hungry, being thirsty, being uncomfortable, being fearful. Then, of course, psychiatric evaluation is needed because in some cases there might be some pre-morbid conditions that require a specific treatment. In some other cases, we will be talking more about late onset psychiatric symptoms that in general raise awareness and concern about potential neurodegenerative condition like dementia. And then, as I mentioned before, evaluating the environment. It is actually very well described in the literature that aspects of the environment and the type of stimulation, the amount of stimulation can actually be a precipitant for some behaviors. The fact that also there's burnout and exhaustion from caregivers can also elicit behavioral problems. I have, for example, this week I evaluated a family where they were saying that they wanted to have dad for Thanksgiving celebration, but they were afraid that he was going to be overstimulated and maybe feel fearful or anxious or agitated. And we came up with the idea of, trying to still having the gathering, but trying to reduce how much stimulation he was going to have, maybe exposing him to too many people at a given time for less time, trying to ask the relatives to maybe speak one at a time, as opposed to, as it happens in these family holidays, that people is speaking one over the other one across the dinner table. Somebody with dementia will have trouble sorting out and filtering information, and then can get overwhelmed, and that can sometimes lead to behavioral problems. So adjustments and modifications that can help tailor the amount of information that is provided to an individual at a given time can actually be just enough in some cases. And that, as you can see, doesn't have anything to do with the medication. Some of our colleagues in University of Washington and Johns Hopkins have actually come up with a systematic way of making an assessment of behavioral problems. They actually call it a DICE approach, which I don't think is that dicey, actually, because I think it's very systematic and not random. The idea is to actually being able to provide a tool, not just to clinicians, but also to family members, of how to actually go through a system of evaluating and describing what is going on, and trying to understand if there might be some factors or conditions that can be remediated, investigate if there are some other potential medical or physical issues that might actually be causing some of the problems. What are actually the expectations of the caregiver, and what might be going on also in the family dynamics, and then to come up with plans of how to actually be able to diffuse situations, how to be able to distract individuals, how to actually be able to control the situation and evaluate. I think it really sounds very nice and easy, but I'm sure that many of you that are attending to this talk today have had the experience that this is not that easy. And I think as a clinician, it's also important for me to recognize that, because it requires a lot of effort. It requires a lot of work. Many times it works, many other times it doesn't work, and then some other approaches are needed, and combination of approaches. So goals of intervention, I think, again, symptoms that can be very disruptive, symptoms that can also create unsafe situations, try to alleviate syndromes, as I mentioned before, some of those potential reversible causes, like having a medication that is causing a problem, or having a urinary tract infection that is also very common. Try to understand how to create an outlet to reduce the burden for the caregiver. And that is something that, again, becomes quite an interesting issue, because I think caregivers by nature become caregivers because of that sense of responsibility, devotion, care, and love that is ingrained in them. So sometimes thinking about oneself and saying, I need an outlet, I need a break, I need a relay, comes with some degree of guilt. What I tend to say to my patients and their families is, okay, you know, feel guilty, but feel guilty for some time and then actually be compassionate with yourself. Because you have to do it. If you don't do it, nobody else is going to do it for you, right? So I think that is very important. You know, the idea is that many families really actually want to keep their loved ones at home. I think that's great. I think we also have to be respectful of values and beliefs of our patients and our families, dignity, autonomy. But I think there are cases in which our recommendations is also to say, well, it seems that with the degree and severity of this set of symptoms in your loved one, more professional help is needed to create a safer environment for this person and for you at home. You know, so even though we like to prevent institutionalization, sometimes that might actually be the way to go. And of course, it requires a lot of trust and conversation between clinicians and families. So behavioral interventions as the first line treatment. Interestingly enough, even though we have the expectations and we have many times the hopes that there can be a pill, a magic bullet that can help with the behaviors, and in many cases it could happen, the evidence in clinical practice, the evidence that we have in literature, even in clinical trials that many of you may have participated or known about, is that behavioral approaches are the first line treatment for behavioral symptoms of in the context of dementia. And again, many of the aspects that I mentioned to you before that apply to the individual have to be combined with taking care of the caregiver. Otherwise, there's also very vast literature about how that wellness and quality of life of caregiver can actually precipitate and in some cases even perpetuate some of the behavioral symptoms. And it's not something to think about as somebody to be blamed. It's just that we're humans. And when we interact and when we're tired and exhausted and depressed, we may not actually have the optimal tools to actually address the situation. And the other piece is that if you think about brain functions, we may lose some higher intellectual functioning, but many individuals with dementia still actually remain able to read what we call nonverbal language and facial expression and the inflection of the voice, you know, speaking slowly. Some of those behaviors can actually be interpreted positively, or if it's actually in a negative connotation, being captured by individuals who have cognitive and behavioral issues in the context of dementia. But again, I'm not saying that this is an easy task. It's actually very taxing for individuals, and I think that's where we clinicians can also be of support to our families. So this actually is a reiteration of what I mentioned before, similar to the DICE approach from our colleagues, behavioral analysis, trying to understand triggers and response. I think it's always important to make observations about what might be precipitants, if it's related to the environment, what might be perpetuating factors, and what might be things that work, that help actually dissipate the symptoms. Definitely safety is a huge issue when you have somebody that has already developed some type of cognitive deficits, and also because making decisions, impulse control, ability to check reality and not distort it is one of the set of symptoms that actually can lead to behavioral symptoms in somebody with dementia. And the treatment, I think this is very important. Treatment shouldn't exceed patients' capacity to learn. So in some cases, the type of approaches might actually be more oriented to behavioral control and maybe redirection, or maybe using like a music therapy, or maybe physical exercise, or maybe just distracting a little bit from the environment, going to another room, sometimes going for a ride. So those are more behavioral approaches rather than asking somebody with already cognitive deficits and dementia to reflect on his or her own behavior. That capacity to self-reflection and self-monitor might be one that is already compromised. Caregiver education is important again, because I think there's a very human reaction to all of these behaviors. I think when we talk about some other medical conditions, it might be easier to understand, like, you know, you break a leg, or you have pancreatitis, or you have diabetes, or you, I mean, it's, you say, well, the individual has this condition, there's a reason for that behavior. I think the problem that we have when it comes to neuropsychiatric conditions, and in this case dementia, is that the symptoms and the etiology really go to the core of who we are as human beings, and how we think, how we behave, our personality. And those are really more difficult aspects to understand sometimes, and to be able to put them on the fact that, on the notion of this is a organic brain-based behavior. Of course, we may have individuals that suffer from personality traits, negative emotions throughout their lives, trauma, but many times those actually may just compound on aspects of cognition, personality, and behavior that are related to a degenerative condition, and they may actually be amplified, but again, I wouldn't actually say that they are most of the time connected to a you know, free will or volitional action. I think that's another piece that I wanted to discuss when you deal with somebody that you love that has dementia, which is that in neurology and neurobiology, we actually, neuropsychology, we say this, the sense of agency, the capacity for agency, of owning our own thoughts and actions and behaviors. And that's, you know, a sense of agency in many individuals with dementia is lost because of the areas of the brain that have been affected. So other behavioral interventions, as you can see here, activity, exercise, redirection. Sometimes say, you know, okay, let's actually go and do something like a puzzle, or let's actually listen to music. I think something that in general in neurology, psychiatry, psychology, we use is that sometimes contradicting somebody might not actually be the best way to go. In the other hand, ethically, you will say, well, can I go along with something that is very delusional and very fantastic, right? And you might not necessarily actually go along with it. Something that we notice that helps is really being able to connect with something that the patient is experiencing, which is the affect or the emotional distress, right? We can say, well, it seems that you're worried about somebody coming and seeing you, or you're worried about not being home. When that person doesn't recognize that maybe it's at home and is requesting to leave, or some cases in which the person might not recognize familiar faces or familiar members of the family. Again, redirection and maybe distraction might actually ways to help. It has been postulated that sometimes leaving the room for a husband that is not recognized by the wife might actually, for a few minutes and then coming back, might actually be enough. Sometimes that might not work. So these are behavioral approaches. So far, as you can see, they don't have anything to do with medicine. So here's a nice set of tips on how to communicate with an individual who has dementia. And I have to reiterate that there's a shift in the role in the dyad. Let's say if it's a spouse or if it's a caregiver and the individual with dementia, there's really a change, and that by itself is a grieving experience for the person that is caring for a loved one, because that person might not feel anymore as the romantic spouse of that individual, but really actually a caregiver, right? And that by itself is another potential source of distress and anxiety. So as you can see in this set of tips, the idea is to actually being able to, respect the fact that this person is not evaluating reality as he or she will usually do it, that there's distortions, that there's misperceptions, and the idea is not to really antagonize. The idea is not necessarily to actually kind of get into a delusion, but maybe to actually be gentle about redirection, diversion, distraction, reassurance, and trying to get back in connection with all those assets and strengths and traits that make that person the person that it is, right? Not to forget that an individual with dementia is an individual with dementia, but it's not a full description of a personhood or a core identity, which of course has changed. But I think trying to gravitate towards those assets and traits might actually be a good way to connect in a positive way. So we have some examples here. A person with Alzheimer's saying, I want to go home. And the caregiver actually, person is at home. So what can you say? Yes, we're going. Well, you can actually maybe ask about how does home look like for you, right? Try to get a little bit of a reminiscence, a little bit of refreshing of aspects that are important for that person. And again, I think sometimes there might be a conflict on feeling that you might be concealing or maybe not telling the truth. And the reality is that you want to connect with something that is truthful, which is that there's distress and that person has other aspects of him or herself that can actually be connected with, that might actually be easier to calm down and reassure. So more strategies, actually, tips to help with, symptoms, I think is also very similar to the previous approaches, that you're trying to identify. You're trying to identify precipitants. You're trying to avoid triggers. And, remember what I mentioned before, that this might not be a volitional behavior or something that is related to a personality disorder as such, but more a personality change. And again, being, as a caregiver, compassionate with oneself and know that sometimes you might be doing the right thing and things might still not be going well, right? And being able to reach out for help. Something that I have been told by individuals when they go to an inpatient psychiatric unit and there's some degree of awareness, they say that the structure helps a lot, having a routine. We have to remember that another aspect of dementia is that the ability to generate something and being able to recognize what are our states of mind and what are the states of mind of others might be affected. So being able to create a set of meaning and purpose for the day or create a structure for the day might not be there anymore and has to be actually created from the outside, has to be created by caregivers and clinicians. And that by itself can help actually redirect behaviors, because you create that framework that individual is unable to create by himself or herself anymore. And then, of course, there are some other modalities that have been tried to help with symptoms, like, focusing on a healthy lifestyle, trying to use sensory stimulation. We know that there's been a lot of studies actually checking on photostimulation, music therapy, even massage therapy, create some comfort in different modalities of perception. That can actually be helpful. So again, recognizing, trying to understand behaviors, trying to understand different approaches, and trying to understand when to seek out for help. These are some of the syndromes that we see that we call neuropsychiatric symptoms, and these are different from the ones that you may see that appear in other stages of life. These are actually usually more late onset symptoms that don't have like a previous personal history or even family history. So they're different, and they actually, once again, let us to think more about the degenerative conditions like dementia. So the use of medications, I mean, there's been different trials of trying to see if medications that we use to help with cognition, like cholinesterase inhibitors, donepezil or Aricept, memantine or Namenda, can help control behaviors, and the results and outcomes have been equivocal. There's really no enough evidence to say that they can be helpful. And depending on the set of symptoms, we may actually use, as we call, off-label medications that we use in other primary psychiatric conditions like mood stabilizers, antidepressants, stimulants, and sedatives. I think there are two medications that we have more robust evidence that can help with some of the behaviors. One of them is called citalopram or Celexa, and the other one is risperidone or Risperdal. But again, not every patient that has dementia or behavioral symptoms is going to actually be prescribed on those medications. I think it depends on the situation. Behavioral approaches, non-pharmacological approaches continue to be the first line treatment. So again, you know, how to help caregivers. I think the use of self-help groups has also been demonstrated in medicine to be very, very therapeutic and very healing. The fact of having other people that has been there, have experience with maybe different approaches, maybe different outcomes, feeling that you're not alone. All of those are actually elements that can be helpful when it comes to what we call self-help groups. And if you think about it, we have self-help groups for almost every medical condition because they have shown to be complementary to any type of clinical intervention, and in some cases even better. So we have Alzheimer's Association, we have NAMI for mental conditions, we have groups of people with diabetes, and different types of cancer, neurological conditions, you name it. And it is because that ability to relate and have sympathy and empathy with others that have actually been on the same road has been shown to be very healing. It is important to understand that care arrangements have to be sustainable. And I think that's one of the challenges that families and clinicians we deal more with. The fact that our loved ones will need, in many cases, 24/7 type of supervision and many times more professional type of help. So it is important to understand, you know, where your limits are, because again, the wellness, the health, and the quality of life of families and caregivers can actually suffer tremendously because of not having arrangements in place that are sustainable. And then, of course, we have our colleagues, clinicians and researchers that are, you know, trying to find ways to help, not just with symptom relief, as we have talked about, but also with interventions and pharmacotherapies that can actually maybe address the etiology of the conditions. And as you may have seen in the news, there's some excitement about it and there's debate about medications, but I'm hoping that we're actually moving into the direction of finding ways to either treat early potential risk factors or to be able to reverse some of these symptoms and provide a better quality of life for our patients and their families as a consequence. So as a summary, with behaviors, you want to understand what might be going on, whether there might be some unmet needs, whether there might be caregiver, environmental, or personal individual conditions that need to be addressed. Trying to identify the problem, see if there are patterns. Sometimes individuals may have more symptoms at the end of the day, maybe because of different environmental stimulation, maybe sometimes because of too much noise, too much stimulation at different types of settings or crowds. Making sure that individual is healthy. Pain can sometimes lead to many behavioral issues because the ability to monitor oneself perception and being able to articulate and being able to convey those concerns is not there. So we need to actually be systematic in checking for those. Of course, we mentioned about medical conditions, infections. And as I mentioned before, connecting with the affect, with the emotional experience of the individual might actually be a good way to find a middle ground, fear and anxiety, and being able to validate those. And then, of course, first-line treatment, non-pharmacological interventions, although at times a combination is needed. And as physicians, we try to be as gentle as possible. We try to use medications very judiciously, low doses, close monitoring, and definitely first, no harm, do no harm, right? Because in some cases, medication might actually be contraindicated, and we have to be aware of that. And then more resources that can help. I mean, there are some other interventions and some other resources that I have seen that can help people. Memory cafes, senior centers, socialization by itself has demonstrated to be protective for brain health. What we call now behavioral activation, being active in activities that are meaningful and purposefully for individuals, it can be helpful. And then, of course, being pragmatic about the fact that you want to provide a safe environment for individuals, like, driving and checking whether that individual still has the cognitive functions to manipulate information in the road, and reaction time, and the ability to have been able to improvise. And then this is an area that I think requires a little bit more of research, and there's been a lot actually on companion services and home care. How much of this actually is usually paid by insurance, right? Because that's the other piece, that many of these interventions sound great and they sound very logical, but it costs money, and that's something that we hope to also bring up to to different levels of the health system, and also advocate for. Going back to Judy's quote from Mrs. Carter, right? Trying to be there for caregivers and try to be an advocate. And then out of the home, when their symptoms have really become unmanageable by caregivers' health is compromised, and maybe professional help is needed, then considering institutions that can provide that care. And again, these discussions have to be carried out mindfully, gently, and with a lot of trust between clinicians and patients and families. And then Mass General Brigham, we have different resources. Some of them have been there for many years. Some others we're developing, but I think it's a beautiful collaboration that we're trying to have more and more in terms of clinicians, researchers, and also educating next generations on understanding these conditions and how to be helpful, how to also be compassionate, supportive, but also academic and scientific about the approaches that we provide to the care and also the study of dementia. And then Nancy at the beginning mentioned that this is one out of other talks that are available, roadmap. And I want to thank you for your attention, and I hope that this was helpful. I'm glad to take any questions or have any discussions with you all. I'm going to stop my sharing here.
Dr. Urizar, if there's no questions right now, I guess I'd like to offer one of my little strategies for the going home, the redirecting. My husband had younger onset Alzheimer's, and towards the end of his trajectory, there'd be times that we would be here in our home and he would say, come on, let's go home. And my method of redirection was, okay, just give me 15 minutes to catch my breath and I'll put some stuff together and then we'll go. And his, he would just kind of be redirected and it would not ask again right away. Or I also wanted to comment on the validity of you saying to validate what they're saying. I mean, imagine not really even realizing how far along you are in a disease, saying something and wanting to be heard and responded to. I mean, my husband said one time is, and is very exasperated by it all, all I want is one decent pair of pants. And, of course, I had 15 of the same kind of pants for him that would work. And I just, responded to him. I said, wow, yeah, I don't blame you. You deserve at least one decent pair, and he'd kind of like, yeah, I was heard. So.
I'm seeing one question here. If an elderly patient has had 2 episodes of difficulty driving in the dark, would this be considered normal because it is occurring at night, or should this prompt a possible evaluation?
I think that's an excellent question, because I think if you think about it, our vision, our audition, our tact for temperature, our olfaction, our taste, all of those sensory modalities are the windows for the brain to capture information from the environment, right? As we age, there's a change in the some of the vision at night and during the day. Color vision might be reduced. There are some conditions, like, for example, Parkinson's and Lewy body dementia, that can also have a very steep actually change in the perception of color and the contrast. So I will say that that wouldn't necessarily mean that there's a cognitive deficit, but I will say that it will require understanding if there's any problem with the perception of light, of colors, of vision, and maybe to try to understand if there's a connection with maybe some other potential cognitive deficits, like getting disoriented visually and spatially. That sometimes people say, I am actually getting lost in this neighborhood where I have driven through all my life, and I do it with the eyes closed, literally, but now I'm actually getting lost. So I think that is important. Actually, that requires some evaluation of whether it's just a sensory problem, a visual problem, or if it's a visual problem that is connected to a brain problem. Right?
Great, thank you. We have another question here. Are there any suggestions on how to help when a loved one is sundowning? We try to redirect, but sometimes it gets to the point where we don't know what to say or do, as we don't want to increase the agitation. Thank you.
Right. No, thank you. That's a very common phenomenon, right? There's a change in the stimulation. As we were just talking about, the visual perception might be different. The ability to process that kind of transition from day to night, and the temperature, all of those, the brain might be less likely to handle. And then, of course, something that might actually help in some of those is to have areas of the house that maybe are a bit brighter, that may actually kind of give some sense of peace, that are less crowded, or maybe actually kind of try to mobilize the person to an area that feels more calming. But sometimes it's very difficult, because I know firsthand experience, and I know from treating my patients and their families, that people try. It's not that people don't try. It's quite a situation, and that might be sometimes one of the moments that you require to see if besides the behavioral redirection, maybe a medication might help to calm down. And something that is used very much in inpatient settings, medical, surgical, and psychiatric units, is to try to have like items that can help redirect the individual, like clocks in the wall, calendars, a window that you can say, you know, this morning or this evening, or, you know, some external, you know, items that can help with redirection. But sometimes it might be quite a challenge, and sometimes medication might be required. Yeah.
Great. Thank you. And Dr. Urizar, how do you convince a person with some mild cognitive problems to get evaluated?
Right, that's a good question, actually. How to convince that person? I think I have dealt a lot with that. I think, you know, sometimes, many times I will say, we have noticed that primary care physicians have a relationship with patients and families, and then they can become like the gateway and the connector to evaluate different aspects of health that require a specialist or subspecialist. In fact, some of you here may have seen that Mass General Brigham have actually been working on some of these models, and many other hospitals and academic centers around the country, actually, on what is called collaborative care, which is how neurologists, psychiatrists, social workers, psychologists can actually work with patients and start to provide some type of specialized guideline and assessment in the context of primary care clinics. Because the reality is that we tend to be more connected to our PCPs, our primary care physicians, and they can do some screening, they can do some initial evaluations that can lead to maybe further referral. And I think that might actually be something that can be tried, because I think it's difficult to convince somebody that, you know, there's a deficit, and one of the aspects of cognitive deficits is the fact that sometimes the ability to being aware and insightful about having a deficit oneself is not there. And it's not just the psychological denial, but it's also related to the aspect of brain function. We in neurology have a term that is called anosognosia, which is the inability to see that one has a deficit. You know, so that ability to self-monitor and self-evaluate and come up with a conclusion might not be there. So it's not just the psychological aspect, but it might also be the biological aspect related to the denial. So maybe primary care physician, I think, might be one way to go.
And could you share any tips for navigating the holidays with a loved one?
Yeah, that's so I mentioned that I had a family just this week saying that they were considering whether it was appropriate to have a Thanksgiving gathering for this individual loved one, actually, that was having some cognitive deficits and maybe some anxiety and agitation. And I think, you know, one kind of very universal principle that I use is that many times it's not a matter of avoiding or not doing what you love to do. I think it's more a matter of how you make adjustments, you know. And because I'm a tennis player, actually, not a good one like the professionals, but I have to say that my idol, Roger Federer, I just gave the example yesterday to somebody. I mean, he used to play maybe 40 tournaments every year, right? And now in his 40s, actually, he has reduced his playing to maybe just 10 tournaments a year, right? So he still he does what he loves, but then he has changed the pace. He has changed the dosage, right? And I think as we age, regardless of whether we have a cognitive deficit or not, I think we have to accept that we may have to evolve. Sometimes we may actually change our tastes and our interests, but sometimes we can continue doing what we love, but we just have to accept that we have to do it at a different pace. So with the holidays, I will say that maybe the family can actually make adjustments. Say, you know, instead of using like the music very loud and everyone talking all at once, let's actually be more mindful. And if we want to have dad or mom around and that person is going to enjoy, we're going to have to be a little bit more mindful of how much stimulation we expose that person to. So that would be my advice, because I think it's very important to keep the identity of that individual within the family, you know. I wanted to add, maybe Nancy, that I have a couple of patients who have said something very similar, that their fear is, as they progress on from MCI, mild cognitive impairment, to dementia, is their fear is to become invisible, to come to the primary care physician, and for the primary care physician to be speaking to their spouse and not to them, to speak about them in third person. So I think that's very important, to actually be mindful of keeping that integrity, that core aspect of who they are. And of course, you make modifications, but you know, keep that person involved, keep that person within the nuclear family, and make adjustments. Just like we do with kids, right? With babies, right? We should do it for our elderly, right? We should do it. I'm telling you that because, you know, I just brought my mother from Guatemala just a few days ago, and she's very embarrassed because she says, you know, I'm putting you all through all this, the wheelchair, you have to put it on the trunk, and you have to help me with the ramp to get into the van and all that. And I say, well, Mom, you did that for our daughters when they were babies, right? You had the stroller and you had to put the car seat and all that. So why wouldn't we actually make those adjustments for you and for each member of the family? So I think making adjustments is important, and preserving that identity within the family is important as well.
Yeah.